Good morning, everyone. First of all, thank you, Dr. Zaida, for the invitation to present this simple lecture. Inshallah, I'll try to tailor it so everyone can get something out of it for all attendees, and even for medical admin. So I try to put things that are important in the management that are not, sometimes we don't think of them as purely medical. When I did my fellowship or my training, I was just thinking of, getting the knowledge of how to do strokes, how to give the thrombolysis, how to stratify patients for thrombectomies and stuff like that. But I think the big picture for stroke is always bigger than just treating a patient. It is always a system. It's always a collaboration. It's always points of management that need to be adjusted and to be looked at differently for every healthcare provider. Because stroke in general affects everyone, young, old, male, female. So it is rising. Honestly, in Saudi, I think we have some data that the number are increasing, contrary to what we have seen worldwide, and there have been some projection, both economically and medically, of what stroke would affect the population in general. So I advise you to look at these numbers. They are available everywhere. And also I need you to look at the acute stroke management protocols and guidelines that was conducted by the Ministry of Health. It is also on the website. Please look at them, because these are the guidelines that will be implemented sooner than later. So we always think of strokes that we need the public to be aware of, because they are the first step in the recognition of acute strokes. So this is, of course, an American data. So if you look at overall, the public knowledge of warning signs of stroke is poor. Less than 50% of 911 calls for stroke can, within one hour, half thought that stroke was the cause. And I thought, we have less than 50% of people, when they call, they don't know what they are calling for, because they just see that the loved ones are not doing well. We know that from the CASPA registry, that fibrinolytic within 3 hours and a 4.5 hours increase from 4% to 28% if the patient arrives early. So the earlier the patient comes, the better it is. So at the beginning, they have looked at what would be the best tool to educate the public. Should we just go and do campaigns? Should we do extensive teaching for the public of what are the signs and symptoms of a stroke? But I think at the end, whatever is simple and straightforward will be remembered and will be kept in the memory forever. So before 2005, they said, okay, let's do it as the 5 suddenlies. This is how we educate the public. And then they said probably we should not do that, because when they have re-evaluated those individuals for the 5 suddenlies, they literally probably less than 10% remember what are the 5 suddenlies. But when they put it as an acronym, like FAST, and they taught the public when there is problem with their face, arm, speech, and then they said time. That means you have to take them immediately to the emergency department or call 911 in the States. So the FAST protocol, and then they added 2 more things, which is B fast. So if the patient has balance problem, eye problem, face, arm, or speech abnormality, each one of them has a very heavy value. Can you please mute yourself, and we'll try to mute everyone from our side. Somebody was talking on the phone on the mic. So if you have one or more face weakness, arm weakness, and speech difficulty, this is almost 88% of all strokes and TIAs. So you don't need to teach the public every single symptom and sign of stroke. So if you teach them only these 3 valuable symptoms, when the patient gets affected by one of them or more than one, then you are catching about almost 90% of the strokes, and you can bring them to the hospital as early as possible. So when they looked at it, like 100% of many individuals remember the 3 months after the facial growth slur speech that there are stroke warning signs, and 98% recall the arm weakness or numbness. So that means we have an extremely high number of individuals who are not in the medical field remember that FAST protocol or FAST acronym will indicate stroke. So whenever you encounter anyone in the public, in-house, in the market, anywhere, FAST is an important thing. So this is the acknowledged acronym across the world. Here in Saudi, we one of our physicians, I can't remember the name now, implemented العاج for people to remember. برضه نفس الشيء كاتبه عين عوجاج في الفم واليد والرجل أكرمكم الله. Now we go back to the next step in our chain of we call it the chain of survival, which is the EMS. And again, we have struggled with EMS over the years where it was not an effective EMS system in the kingdom. And I assure you that this is going to change 100% within the next 10 years maximum. I would say 5 years, I bet, but I think 10 years for sure. And you can see it in Riyadh, in I think التجمع الثاني والثالث that is I think with King Fahd General, King Fahd Hospital, King Fahd Medical Complex. They have triaged the first case through EMS with someone who presented with major stroke, and then they called the ambulance, and the ambulance immediately had dispatched the crew, and then they took the patient immediately to the hospital, and it was an effective system. And this is one of the systems that we have worked on over the last 3.5 years. Alhamdulillah, we have seen it applicable. It was done last month, and I think this will spread across the kingdom. So the EMS, inshallah, it will be an amazing system that is incorporated with our emergencies across the kingdom. So for the EMS, it's important. There are many important things that need to be done on the scene. So I won't bother you too much with it, but it's made basically. They have to evaluate the ABCs, look at the saturation, make sure the patient's not hypertensive, make sure that they take proper history, time of onset, ask everybody in the surrounding if they're not coming with the patient, make sure that, as I said, infuse IV fluids, try to avoid anything with dextrose because it might exacerbate the cerebral injury and make the stroke worse. So the EMS can establish the IV line, make the life of the emergency physicians and also people in the ER easier. They will take some blood samples so it can be processed immediately. Sometimes with some of the EMS, they can process also basic blood works. As I said, they will take focus history, make sure that there is nothing else that is attributed to the presentation of the patient, may take proper history of medications, recent analysis, trauma, and surgery. So again, we just stress the point that this is one of the important acronyms that we need to remember to evaluate. This is for the public. And actually, even it's important for some of the healthcare workers who are not 100% being educated with the signs and symptoms of acute stroke, and I think has to be adopted everywhere. That's another card that is distributed to the public just to show them what do we mean by the FAST protocol. And this is the P100 for the evaluation and management of potential stroke patients as supported by the American Stroke Association. So once the patient is dispatched from the home or from the scene and comes to the emergency department, what should we do? There are a lot of misconception about acute stroke. In many hospitals where they have established pathways, the protocol appropriately in emergency, after you apply strict protocol right from the triage, you can see your numbers just fly up just by establishing a pathway or a protocol. And that has been seen and also established in multiple hospitals across the world. So your first task is to establish proper pathway and to ensure that emergency know about it and emergency apply it appropriately in the hospital. So creating a pathway is not something of luxury because it's something of importance. and it is extremely important to increase the number of thrombolysis and also the number of patients that you are saving. And as I said previously, the most held idea that patients do not come in the right time. We had the experience in the King Abdulaziz University. We have a very strong protocol, strong service that we are running since 2012, where we enroll the first patient, and then now at least we are thrombolizing 1 to 2 patients per week, and we have thrombectomy at least 6 a month or more. That did not happen in 1 or 2 days or 2 months or 3 months. It took a lot of time and a lot of persistence. So if we need to have this, we need to have persistence, we need to have acknowledgement from all departments, and I would really encourage everybody to put their hands, because this is something that we do for the community. It is something that we do for everyone around us to prevent a crippling disease, because we know this is the first cause of disability across the world. It is deemed to be third cause of death across the world, but recently they have pushed it to second cause of death. So it is a major cause for morbidity and mortality. So treating it is not a luxury. Treating it is an important thing in a hospital and also in any system. So we always have to think of the structure chain of survival to improve identification in the emergency. So by using template, time goals, hospitals and emergency can create effective system for optimizing stroke care. You always have to think of the 7 Ds or the 8 Ds, where it is important to detect stroke. You have always to think how to dispatch that stroke, then how to deliver that stroke to the hospital, and then door to emergency department triage. And then it's important to always have data, and then decision, and then drug administration, which is mainly thrombolysis and thrombectomy. So in the triage and the initial evaluation, you always have to label acute stroke as a super emergency. Everything has to be pushed away for acute stroke to be processed for everything, for blood work, for imaging. So it has to be equal to MI or major trauma. So in a hospital, you always keep the acute stroke patient in the trauma bay. So the initial evaluation has always to be ABC. Then we have to think or to examine for neurological deficit, which is NIH stroke scale. You have to have early implementation of stroke pathways, and you have to also notify stroke team as soon as possible. The single most important history is the time of onset. When was the patient last seen normally? So that we always stress when we take the history, because we want to make sure that we are thrombolizing people who had been, classically within 4.5 hours or within 24 hours for thrombectomy. But again, this has been changing in the literature. We used to treat strokes based on time factor. Now we're all saying that we are treating stroke based on tissue, not time. So time is irrelevant in the Stephen Hawking. So when symptoms completely resolve, then we have to reset the therapeutic clock, especially about the availability of therapeutic intervention like TPA. You have to go over the indications and contraindications. In the examination, keep it as simple as possible, but it's always important to, again, ensure the ABC is well. Look at the pressure, the heart rate, the SATs, the temp, and you also have to do the NIH stroke scale. It is extremely important for people who are assessing patients with acute stroke in the emergency to be confident in conducting the NIH stroke scale, because this is the number that we are communicating on the phone when we evaluate acute stroke. And if you go to the website in the IHSS, you can take probably 30 to 40 minute education program and video. At the end, you'll receive a very nice certificate that you are an NIH stroke scale administrator. So please go into the website, get familiar with NIH stroke scale. They have very nice videos, and it is very easy to pass through it and also to have the certificate. So in the examination, as I said, I'm going back, do the basics, do the NIH, and then look for other causes of symptoms, potential causes for stroke or as potential causes for alternative. And again, take proper history of their medications, cardiomyopathies, listen to the heart murmurs, the failure, and stuff like that. This is the NH stroke scale, and basically it will look at the level of consciousness. We have questions for it. We have to evaluate their gaze, their visual abilities, facial palsy, the presence of it or not. And then we examine each arm alone or with each limb alone, right and left, upper and lower extremity. We evaluate for ataxia, sensation, language, dysarthria, and system inattention. And for each one, it has a certain number that you can give to the patient. So if a NH stroke scale is 0, that means the patient is perfect. If the NH stroke scale is higher, that means the patient is more impaired. So here is when we say the more number you get is not that you are excellent, the more number you get that you are poor. The higher the number and the more impaired is the patient. Okay. So these are the international recognized time factors that we always have to keep in mind, and we always have to evaluate when we are looking at the KPI. So once you establish something like acute stroke pathway, acute stroke management plan, you always have to keep these numbers in mind, and you always have to fulfill these numbers. Some hospitals have even excelled and did way better than the time I'm putting up. So from the door to seeing a physician or a triage nurse, it has to be less than 10 minutes. So anyone who comes through the emergency with any possible symptom of stroke has to be triaged, as I said, with the utmost, the highest level of emergency. Door until the stroke team is seen, or one of the members of the stroke team has been seen, should be less than 15 minutes. Door to CT initiation, meaning to go to the CT scanner to be done, is less than 25 minutes. Door to CT interpretation should be less than 45 minutes. And then door to drug administration, that means from the door until they get the TPA, or there is another number for thrombectomy. But for the TPA, the IV TPA should be less than 60 minutes. And then door until they get into the stroke unit, it should be less than 3 hours. And it's always important, as you all know, that time has to be kept in mind always, and you have to maintain time properly to save the patient and also to improve their outcome. This is what we need to do. So all patients will have to get CT scan, just plain CT, do glucose, oxygen saturation, do the renal function, CBC, and then look for cardiac ischemia, electroponin, CK, look at the IR and PTT, and then do an ECG. Not everybody gets the other ones, but these are the basic that almost everyone who comes through the door should have these. Honestly, with the current thrombectomy trials, I would add imaging of the vessels. So either CT angiogram or MR angiogram on the spot is of extreme importance, and again, CT perfusion, because we depend on much of the decisions on perfusion and CT angiogram, and this is also our protocol in the university and in many hospitals. So once patients leave an acute stroke, they will go for CT brain and then CT angiogram plus minus CT perfusion. The importance of non-contrast CT scan, it is the pillar for acute stroke. So you don't have to have MRI, but if you do, then well and good. But for the acute stroke treatment, it is only enough to have CT scan to treat patients. And there is also aspect score that is important to know about before you treat any patient. But again, what you need is only plain CT scan to judge this patient is eligible for thrombolysis or not, based on certain criteria. It's mainly loss of gray-white differentiation, distension of the basal ganglia, sulcal effacement, hyperacute MCA sign, or hyperacute basilar sign. These are the other. For the MRI, as I said, MRI can be done acutely. So if you are going to let's say, make MRI the standard of care in, let's say, in all acute strokes, what you need to do is just get T1 flare and DWI. And most important for ischemic stroke is the DWI, because it is more sensitive and more specific. Sometimes even early on, the flare, the T1, the T2 can be totally normal in acute stroke. So it is diffuse weighted image that you need to get. And if you want to cut it down to one image, because it is very fast to get diffusion, just get diffusion images if you think that the patient has ischemic, not hemorrhagic. Hemorrhagic, you have to have other images. And as I said, MRI is more sensitive than the contrast, the non-contrast CT scan, and it is extremely sensitive and specific. It's also important to evaluate TIAs, because many TIAs we don't see them in the CT scan, and also not all TIAs can be seen in MRI. It's only 39% of those patients who present with TIA will have positive MRI, and up to 61% they will be negative. So even if the MRI is negative, a patient has classic symptoms or classic neurological symptoms, then you always have to say this is TIA, and you don't depend on the MRI for it. I said before that CTA is important. It's becoming more of a standard of care, and in many hospitals they implement CT angiogram because it has very high sensitivity, specificity. The importance of CT angiogram, it will show you where the clot is, it will show you where the stenosis is. Most of the protocols for the CTA will take the images from the heart, meaning of the arch of the aorta, up to the level of the vertex, so you can see the whole arterial system. So you see the arch of the aorta, the origin of the carotid, you see the internal carotid. So right from the beginning, when the patient comes in, you all know that this patient will need endarterectomy, will need stenting. You know that the patient will need, let's say, combined IV thrombolysis and thrombectomy. So CTA is extremely important, and inshallah in the hospital we'll make sure the CTA will be implemented in any patient who has acute stroke. Now we're doing it for everyone that we admitted in the last month, almost everyone, but I'm hoping that we can do it for everyone who comes through the door with acute stroke symptoms, because it is extremely important to stratify patients who are, even for TIAs, it is important to do the CTA, because you can stratify them into, let's say, a high likelihood of having another stroke if they have carotid stenosis, or low likelihood if the CTA is normal. This is the concept of the ischemic penumbra, where when you have a clot, that let's say in the MCA, there is core that you cannot salvage. This area is dead, and whatever you do by opening this vessel up, you will not improve anything, and that area is dead, and that's why we always have residual of a stroke, even if we treat with thrombolysis. Alhamdulillah, with combined IV thrombolysis and thrombectomy, the outcome sometimes we can reach to in IH stroke scale of 0, when the patient who comes back to normal, and that happened so many times. But again, even don't get discouraged if you treat the patient and still the patient has deficit. That's why we go back to the basic that we have to do in-IH stroke scale at the beginning when patient presents, and then we do the in-IH stroke scale after we treat. So this is the only solid finding by numbers that we have improved the patient, or we have, let's say, deteriorated him, or make him deteriorate by treating him. So the NIH will tell you, oh, a patient has an NIH stroke scale of 20 for treatment, and then drop down to 10, so there is a 50% improvement in the clinical status. So you have solid number that you go back to, rather than saying, oh, I think he is better. He used to lift his hand up, and now he's, have more power. So that doesn't work in terms of assessing properly what the improvement is. So going back, the core is the dead tissue, and this is what we are trying to save. The distal arteries that are supplied by the middle cerebral will eventually be deprived of blood, and it will eventually become a core. So instead of going, with nothing, and then small core, with time, if you don't open that vessel, the whole area at risk, which is the penumbra, will go into a core, and it will be a dead tissue. So it means salvageable tissue into dead tissue. This is the schematic representation of how it will happen. This is the infarct volume. This is the flow in the brain, and this is the scheme of how things will go. So if you see with me at the beginning, we started with this infarct volume that is, let's say, 110 milli, and we started to see that there is some core developing. The clot is not taken out, so this area is becoming darker and darker. And then with time, you can see time passes, there's more oligemia, and then you can see that there is more infarct core. And if you don't open that vessel, with time, the infarct volume will increase, and the whole area will go infarcted, and it is a dead tissue. So patient will get worse. And that's what we also see clinically when we don't treat patients with thrombolysis, or when we don't recanalize. Patient will initially present with weakness, let's say, of the arm, and then they will have dense hemiplegia. Why? Because the area of the penumbra has already died in the next few days. So at the beginning we would discuss it, because most of these randomized clinical trials which were done for IV thrombolysis were negative. They tried with everything, streptokinase, alteplase, they tried different kinds of protocols, but failed at the beginning. And I have multiple reasons why these failed. But let's just go to the right side, which is the groundbreaking study, which is the NINS trial, which was done in 1995, where they have done it based on the pooled analysis of the Atlantis and the ECAS, which said that probably we have improvement of patients when you give thrombolysis. ECAS 3, it confirmed the 4.5 hour time window. The NINS told us that we can treat up to 3 hours. So from 1995, we have been treating patients with acute stroke. The time factor was 3 hours, and then it changed around 2008, where we extended that trial to 4.5. The IST is one of the important also landmark trials that are important for thrombolysis. So in that time, the FDA approved thrombolysis since 1996. The Europeans were a bit later. They approved it 2003, and the full approval for the Canadian was until 2005. Now it is grade 1, level A recommendation by the American Heart and American Stroke Association. Basically, they looked at, let's skip all of these, but the important thing to remember after looking at the numbers, that the proportion of patients with minimal or no disability had increased from 38% with placebo to 21% with TPA. There is absolute improvement of about 17%. They have a better scheme outcomes. And if you look at all of the outcome scales, the NSR scale, the Glasgow outcome, the Rankin, the Barthel index, which all evaluate outcome data, you can see that TPA had done much better than placebo when they are given the TPA in 3 hours. So this is the first trial that proved that TPA works. So in the treatment group, as you can see, there is also a cause for it, which is bleeding, and the general number that we always quote for patients is 6%. So there is 94% chance of taking the medication and have no bleed, and there is always risk, which is 6%. You always have to disclose that. But if you look at this asymptomatic, for the treatment or placebo group, it was 0.6%. So it was significant. And for the symptomatic people, that was 6%. Patients who were asymptomatic and were treated also had higher level of bleeding. That means TPA also increased the risk of bleeding, yes, but it did not affect the overall outcome. If you know some of the trials, when they look at, let's say, antiplatelet, anticoagulant, they look at the modified Rankin scale at the end of the trial, and if the bleed has outweighed the benefit of, let's say, the treatment, which is antiplatelet or anticoagulant, then we say, oh, at the end there is no benefit. But despite the level of bleed or the percentage of bleed that happened with TPA, we still did not outweigh its benefit for improving patients. So the degree of improvement or the level of improvement was way, way, way better than the amount of bleed that happened in that trial. This is a very beautiful image telling you exactly when you give patients TPA. So these are 100 patients that are given TPA. For every 100 patients that you treat, 32 of them will be benefited. Okay, you will only harm 3, and death happened only in 1, so 1%. The number needed to treat NNTB meaning the number needed to benefit. So you have to treat. Look, this is an extremely good number, and I will show you the other numbers that we took for granted for many years, and we always blame, thrombolysis for acute stroke, that it doesn't work. The number needed to treat or to benefit in patients with acute stroke, you have to treat 8 patients to see 1 benefit in 1 patient. To be back to normal or near normal, you only have to treat 3 patients to see 1 of them improving. That means any kind of improvement. You'll be surprised by the next slide. Coumadin or warfarin for atrial fibrillation, the number needed to treat is 27. So you have to treat 27 patients to see a benefit in 1 of them. Thrombolysis for acute MI, where we have treated millions of patients, 27, and in some reports 38. Aspirin for acute ischemic stroke, you have to treat 77 patients before you see benefit in 1 patient. So this is by evidence, by number. It works and it is good, and the number needed to treat is extremely low, which is extremely important and extremely good. So in routine clinical practice, they have evaluated the use of TPA because there had been a lot of voices in the literature and also in the emergency department claiming that neurologists took bribes. Exactly this is what happened. Emergency physicians was led by one of them, I can't remember his name, thought that probably TPA was a shady drug and it was, drug company driven. And for years they have fought against it and they say it doesn't work and you need to be vigilant before using TPA and you have to do this and this and this and that. So these trials came out. These are registry trials, which is what we call after-sale trials. It is not supported by pharma, and it proved that TPA works, and the numbers that they have came out with the rate of ICHs in those trials was up to 6%, even lower in some of them. There is cost effectiveness of using the TPA, and still we are underutilizing that major drug in our clinical practice. This is just one of the landmark trials, which is the ACAS-3, where simply it said that we can treat up to 4.5 hours, and the guideline had changed after this paper came, and a lot of meta-analyses that said that yes, we can treat patients up to 4.5 hours. But again, extending the time window does not extend you as a physician to relax and say, oh, we still have time. Because the earlier you treat, once the patient comes to the emergency, the better it is. So it's always time. You have to push to break the time factor and to be as fast as possible and as early as possible. This is just a review of the ACAS-3. We'll not go into the details. At the end, you see, this is also one of the reassuring things that a lot of emergency guidelines have changed their stance. When they looked at the symptomatic intracranial bleed in the 4.5 hours was even less. It was 2.4%. It was even less than 6% when we have treated patients earlier on during the 3 hours. So as I said, it is important to think of it as time for the patient, not time for you. You always have, even the patient, if they come within 30 minutes, you always have to maintain the time factor that I told you about. When it comes to indications and contraindications for TPA, this is the absolute contraindications. And as I said, I did not say it before, but for the absolute and the relative, many things have changed. I did this lecture, years ago. I did not update it. Some of them we don't take it as an absolute. Let's say prior history of intracranial bleed. It used to be an absolute contraindication. Now the data and the literature said probably not. Also serious head trauma in the prior 3 months also still an absolute contraindication. But we always have to think about it in what's the extent of the trauma. Do you have bleeding inside the brain? If they have suffered what type of trauma, opens, closed, contusions versus ICH. So all of these have to be taken into account. So it is not an absolute anymore, because with each one of them we can always have to, rethink it again and see what is the benefit of giving the TPA versus the potential bad outcome that may happen. For the ER, so all acute or any acute any suspected acute stroke patient would also be less than 3 hours. And as I said earlier, 3 hours was the old digit. Honestly, what we are doing in our emergency in the university is that anything that comes within less than 6 hours, we will process it as acute stroke. But it is not wrong if you say, no, I will be very strict. Anything that comes in less than 4.5 hours, do it or process it as an acute stroke. Some people now say, oh, anything that comes within 24 hours, okay, you have to process it as an acute stroke and do all the stuff that you need to do for that. It is still debatable. What should you implement? It depends on your emergency, and also it has to go in collaboration with your colleagues in emergency. Because we don't want to overwhelm the ER, because anyone that comes with any kind of facial weakness, we have to process it as, acute emergency or acute stroke pathway. So always has to be looked at, and you have to tailor whatever protocol that works out with your hospital. So initial evaluation, stroke or activation, and then you go for blood test, ECG, and then INR. You go through the pathway. And I think it's important for all healthcare workers in emergency to know what would be our pathway in the future. This is also, as I said, for 4.5 hours. What you have to do, you have to go through the pathway. Now we'll go. I'm not sure. Do I have time? Now we'll go to the next, let's say, major advancement in stroke treatment, which is thrombectomy. When it came out, I'm just going to tell you the name of the trials, but I will not go into the details. I'll go into detail of one of them, just the positive one. So at the beginning, they looked at the possibility, where they said, okay, in any large vessel, when in MI, they have shifting paradigm where they have treated patients with thrombolysis, and then they said, oh, if we take the clot out, I think it is much better, and they have proved that thrombectomy and ilectomy at certain hours, and that's familiar with the Hartman, can improve a patient better than thrombolysis. And the same thing was thought of in acute stroke, and they said, probably if we take the clot out, this is much better, and we would have better outcome, because you will go directly to the clot, take the clot out, and then recanalize. What we need to do is recanalization. So they tried with the synthesis trial, which is a negative trial. They looked at the what would be the outcome if you go and do endovascular treatment and fragmentation of the thrombus. Would that improve the patient outcome on the long term? And there was no different outcome, either in MRS or if you stratified according to the time. Then the IMS3, which is one of the major trials, where they have divided the treatment into 1/3 of the dose of the TPA is given, and then the patient will be taken immediately to the angio for thrombectomy. And again, this trial was negative. There was no difference in outcome between IV TPA and vascular proof. There are multiple reasons why these trials have failed One of them is the device that they used at the beginning. It was not really a good device. The other thing is that they did not even do CT angiogram or angio, any kind of vessel imaging before they stratify patients into the trials. And also the time. They have a lot of delays when it comes to taking patients to the angio suite. And these are the three major reasons why these two trials, or multiple other trials, these are the two major ones, but there were also other smaller ones that showed thrombectomy doesn't work. And for years they have tried. Like I think they have tried the thrombectomy trials from the early 2000s until 2015. This is the first positive trial that changed the world of thrombectomy. 2015, Mr. Clean came out. It was a superiority trial with 500 patients, and they have looked at patients with proximal intracranial occlusion, either in the distal ICA, middle cerebral, in the M1 or M2, or ACA in the A1 or A2, which has to be seen in CTA, MRA, or digital subtraction angiography, and they have to have at least some deficit, more than 2 in a stroke scale. So vessel imaging should be done before or during IVTPA. You have to take patients for endovascular treatment within 6 hours. Patients were allocated to either the usual care or the usual care plus IA or thrombolysis. So intraarterial thrombolysis or intraarterial treatment with fibrinolytic agent or mechanical thrombectomy or both. So 64% of the population were enrolled, had M1 occlusion, and 27% had occlusion of the ICE and the M1. So 195 out of the 233 in the endovascular treatment, also to groin puncture, was about 260 minutes. And this can be done in any hospital. So 260 minutes, it is nothing. Yeah, I mean, if you have an endovascular team and if you have your angio suite ready, you can achieve that. So it is easy to achieve. It is not one of the numbers that is difficult to break. It's one of the numbers that are actually, even in MI, they can achieve that 260 minutes. 260 minutes معناتها كم ساعتين 4 ساعات شوية صح؟ So يعني تقريبا 4 ساعات ونص for from the time that patient comes to the emergency to the angio suite, 4.5 hours is very limited. So you can do that, you can achieve that. And that's what is the beauty of this trial, where they did not come up with numbers that are only designed for trial. No, this is numbers that you can achieve in the public and also in all other hospitals. So the adjusted odds ratio of improvement was 1.6 in favor of intervention. There was an absolute difference of about 13% in functional outcome or independence. MRS 0 and 2 in the patient means that the patient is independent, and it was in favor of intervention. 32% had MRS 0 2 in the intervention group versus those who did not. There was no difference in mortality. There was no difference in the rates of intracranial hemorrhage. And most patients received IVTPA before they went into the thrombectomy. And the onset until reperfusion was about 332 minutes, يعني تقريبا 7 ساعات. There was marked decline for benefit of reperfusion after 6 hours and 19 minutes. And then the other trials came out. The ESCAPE, the SWIFT Prime, STIND-IA, REVAS-HAT. These are the big 5 trials that that were done on thrombectomy, and all of them had been positive, and all of them had said the same. Some of them, included patients up to 6 hours. Some of them included up to 8 hours. But the end, any patient, after these trials in 2015, the guideline had changed. Anyone who comes with acute stroke and have large vessel occlusion, meaning ICA or middle cerebral artery occlusion or anterior cerebral artery occlusion in the proximal part, they should get thrombectomy if they come within 8 hours, period. So across the world, this has changed the face of treatment, the face of the world in terms of acute stroke treatment. And it is extremely important to know this is the standard of care. It has to be applied. It doesn't have to be in every single hospital across the region, but there has to be at least some centers that have this ability. And again, the Minister of Health now is moving toward, optimizing the care and also in stratifying, let's say, hospitals into different levels. And stroke has been one of the major things that we are looking at each hospital at their capabilities of acute stroke. So you are either stroke-ready hospital or primary stroke hospital or comprehensive stroke hospitals. And even payments in the future will be based on your stratification. So if the hospital is not ready to get or to give proper care for the acute stroke patient, then they will not be stratified as comprehensive, and then they will not be referred patients. They will be reorganized and rerouted to other places across the region. These are all the analyses of the 5 trials, and simply it all said as the same thing as I'm saying, is that thrombectomy now is the standard of care. It has to be done. So as I said, these first trials said it is up to 8 hours, but again, things have changed because this trial came out where they have evaluated thrombectomy 6 to 24 hours after stroke with a mismatch between deficit and infarct. And that also looked at patients who are presenting with wake-up stroke or after 6 hours. Do they benefit from thrombectomy if they have a lot of vessel occlusion? And the answer was yes, yes, yes. They improve and they do much better than patients who did not go into a thrombectomy, given the fact they have to have 2 things. They have to have CT perfusion proving that there is penumbra, or we have to see what they call it mismatch between flare study and diffusion weighted image. So if you do that acutely and you prove that the patient has some visible tissue, then you should go for thrombectomy even if they have crossed the number of 24 hours. And just yesterday, there is also a big paper published in New England Journal, and that paper said that thrombectomy even works even if you have hypodensity in the brain. So it came out of Japan. It is called Rescue Japan. So they have looked at thrombectomy in patients who are majorly disabled, but they have abnormality of the CT scan, meaning they have hypodensity in the CT scan, and their aspect score was 3 to 5, which is very low for any kind of treatment. And despite the fact that they have hypodensity CT scan, thrombectomy worked and improved the patient outcome. So their MRS at the end of the trial was much better than those who did not undergo thrombectomy. So don't hang into the results of this trial, but I'm just saying this is just yesterday, just to show that thrombectomy is changing the world of acute stroke, and you have to have a grab at it before you lose the let's say treating patients properly, and because the world is moving toward that way, and also the kingdom is going toward that way. I think I will stop here, and I will take questions if there is any. The question is, do we have to wait for serum creatinine in every patient before doing CTA? I think that was, if you go back to the literature, that question was addressed. So in the absence of any clear renal history in the patient, because of the emergency of the situation, and if you needed the CT angiogram, then you can proceed without creatinine, and that is supported by literature. It is not me saying it. But in the reality, in practicality, بس عشان you don't know, a lot of people get sued for it. I would rather wait for the creatinine before doing the CT angiogram, just for practicality. But even if you do it, I tell you there are lots of papers that says you can do that on the merit that this is an acute emergency, this is a super emergency, and neurons go over nephrons. And even patients have, let's say, لا قدر الله, يعني, they encounter renal impairment. You can deal with it later on. So neurons over nephrons. The second question, will you give TPA in person with severe stroke, either by image or by aspect? So for the first one, NIH, هذه كانت an old theory that severe stroke should not be given TPA because the risk of hemorrhagic transformation is high. And that question probably in the 1990s or early 2000 was valid, but now it is not. TPA, can you please unmute? Somebody's talking on the mic. NI stroke scale, any level of NI stroke scale can be treated with TPA, either low or high. When it comes to aspect, no, not any aspect can be given TPA. Anything, let's say, aspect of 6 or more, then you can treat. So it's a two different questions in one. I hope this answers your questions. Any other question? عفوا بس لا.
السلام عليكم. يعطيك العافية دكتور عمر، ما شاء الله على البرزنتيشن الرائع، يعني استفدنا كثير جدا والله. أبدأ أريد انفورميشن، أعتقد إنه الحماس حيكون للجميع. إنه we face lots of cases that it came to us in even hyperacute status, but now I think with this kind of protocols we can safely and administer this kind of therapy for these patients. You know that I'm radiologist, and time factor is very crucial in these cases. And in MRI we have the fast 7-minute even protocol that can use for stroke, including SWR that can predict hemorrhage, even petechial hemorrhage. Although I know that petechial hemorrhage is not contraindication of your therapy, but at least it gives us an idea. The project I want to comment about the creatinine. Unfortunately, in some cases, even when they had the creatinine, they didn't calculate the GFR. GFR is a cutting point, not the creatinine. If your GFR is more than 60, go ahead. Even the creatinine is high, little bit, go ahead, and we can give the contrast for any case, not only like this emergency. Between 30 and 60, this is the area of question. When the risk factor, maybe we need a consultation from the nephrologist. Below 30, this is patient most likely will need dialysis after the CT angio. But even all these numbers, patient can be given the contrast with some precaution. And I agree, the neurons is more than important than nephrons. Thank you, Dr. Amr, for your lecture. Enjoyed it.
شكرا دكتور، الله يعطيك العافية. يعني we are blessed with your presence. Anything that they ask for in radiology, you just fulfill it in time. Thank you. I see Dr. عماد raising his hand. Dr. عماد, تفضل.
أهلا وسهلا دكتور عمر. Very very difficult to have you speak about stroke. Dr. Amr, my question is in case of is there a difference between TPA and Nictopase or Nictopase?
Nictopase. So now the Nictopase or TNK, this is the new bright for acute stroke. It came into action recently, like let's say in the last 7 years. As we speak now, we are going to be strict to the guideline. The best suit for TNK is to infuse it before the patient goes to thrombectomy. This is the best evidence for it, that it is maybe better than IV TPA if you give it in the context that you are going to get that patient to thrombectomy. All the trials that were done on TNK versus IV TPA or IB-10K versus IB-TPA, they were non-inferiority trials. That means they are as equal to each other. The beauty of the TNK is that it doesn't need infusion. It's just a bolus, easier to administer, and we don't see major side effects with TNK versus TPA. So they are almost similar. So honestly, we asked this question across stroke neurologists across Saudi, and they are using it, and yet nobody still has the guts to change their practice because they are used to the TPA. But honestly, if we have it here, and I know that we have it, and we want to implement it rather than TPA, then why not? It is very well supported by literature.
يعطيك العافية. Yeah, and one of the challenges was we did not have TPA, but we have literature for TNK. What literature, as you said, is very strong. So, yeah, why not?
الله يعطيك العافية دكتور عمر. شكرا جزيلا. دكتور علاء الدين. unmute دكتور علاء بس عشان ماني سامع.
دكتور عمر السلام عليكم.
أهلا وعليكم السلام.
شكرا جزيلا. Very nice presentation. جزاك الله كل خير. Very informative. And I just have one more question about the microbleeds. How many microbleeds you can give TPA with if the MRI showed some microbleeds?
طيب هذه كانت ترى mainly a question that came out of the East, of the Japanese trials with Chinese. طبعا we know إنه في Asian population they have a lot of كيف أقول عندهم local atherosclerotic disease, and they have a lot of cerebral microbleeds. Honestly, when I look at the literature, there have been the ups and downs with. Sometimes they have frightened people, and a few of the papers came out of Singapore, Japan, where they said, when you see lots of microbleeds, this is one of the contraindications of TPA, and they have looked at probably 10 or more. Sometimes they say 20 or more small microbleeds in the GRE. But that was proven not right across the years. And هذه كانت في probably 2002 or 2004, something like that. But then they said no, probably microbleeds is not a contraindication, and they did not prove that it increases the risk of hemorrhagic transformation or symptomatic intracranial hemorrhage. في recent paper, I can't remember exactly, كانت والله 1 or 2 years ago, where this question was raised again. Should we, half the dose? يعني احنا الحين بنعطي 0.9 milligram per kg for IB-TPA. They said probably if you see someone with cerebral microbleed, you should give 0.6, and they proved also it was a Japanese paper. They proved that 0.6 works as maybe as good as the 0.9 in the Asian population, especially in those where we have the possibility of microbleeds. So honestly, the answer is not very, very clear. Until now, I don't depend on the presence of microbleeds or changes in the GRE in consideration of IB-TPA, because for some multiple reasons. One of them is that we always do CT scans prior to giving TPA, and most of the protocols that works with MRI, عادة they do only flare with diffusion weighted image, or ADC map, that they don't do GRE. And to be honest, even if I see microbleeds, then I would say if they are multiple, and they're huge, and they are cortically based, we indicating probably cerebral amyloid, then when patient can very old, maybe I would put it into consideration. If it is not, let's say, cortically based, patient is young, when deficit is large, then I would go ahead with it, لأنه I'm still supported by literature. That's the way I've clarified.
شكرا جزيلا. جزاك الله خير.
الله يكرمك. We are blessed with you, Doctor.
Thank you. جزاك الله خير.
والله شوف انا ما اعرف مين عندي سؤال ثاني، بس انا والله I'd like to thank you so much يا عمر.
سوري
دكتور عمر.
دكتور ايوه سوري معلش.
أنا والله I'd like to thank you so much. صراحة very informative. I learned a lot بالكونسبت يعني. بس أنا I'd like to have what's your like focused message for our teams from nursing, from doctor point of view, either from the emergency, from the patient, from the nursing point of view. ايش الفوكس مسج اللي we can deliver it to make sure we pick up the patient as soon as possible and we provide appropriate and timely manner care for the patient.
طيب the most important message هذه across حتى كل الhospitals they say even if you overcall for stroke it's not a problem. If you ask anyone who's working with acute stroke في كل المستشفيات they will say the majority of what we see an overcall but we are happy with it. I would rather be overcalled for a possible acute stroke rather than undercalled and then we miss a major one that we could have saved that patient. So this is one of the important things. Please, even if you suspect, like it's all also again, but it is supported by data. The in-hospital stroke when it happens, it is one of the mostly that are getting missed, and it is even better for a patient to have stroke outside the hospital than in the hospital because the pickup rate, unfortunately, في كل systems في كل العالم. Still bad. فعشان كده if you suspect any stroke or if you have any question about stroke, please pick up the phone and call us. Let us know. لأنه it's important at this stage. يعني هو it will شوف في كل in every hospital it passes through the stage where sometimes you will get overcalled until people get confident to know what is this and what is that, and then they will readjust and then go back to the usual or what is supposed to be. The second message, I think, for everyone who's hearing us, I think we have to start, let's say, many small workshops. Me and myself and Dr. Saeed, who's the other stroke neurologist, we would like to sit in groups with emergency, with internal medicine, ICU, everyone who's with all the nurses, of course. They are the frontliners. We want to sit with them, go over the protocol, so everybody is on board of the presence of it, and also the implementation of it. These are the two important messages that I need everyone to help me with. And please reach out, send us messages, send us through the department or through the admin that we need to arrange for workshops, and also we will reach out for you so we can sit and discuss these protocols. That's it, Dr. Yahya. Anything else? Okay. Probably. If there's no more question, I think I will in the lecture for today. Thank you for your presence, and I appreciate the invitation. Thank you very much.
Thank you, Dr. Umar, for this informative presentation. We're happy to see you all and see you, inshallah, next presentation. Thank you for